in 2 years.
I wanted to get your comment on one of your colleagues, Dr. Steffi Wohlhandler, professor of medicine at Harvard University, primary care physician in Cambridge, co-founder of Physicians for a National Health Program. We spoke to her in September and asked her about the Massachusetts plan that includes the individual mandate.
When the individual mandate was rolled out this past year, we saw no improvement in the number of uninsured in the state. We actually saw deterioration in access to care. The previous year, they had rolled out a Medicaid expansion. That worked. That got some people covered. But when they rolled out the mandate this year, there was no improvement in the number of uninsured. The Census Bureau just announced that only half of the uninsured were covered by that Medicaid expansion. It also found that there were 5.5% of people in the state uninsured. That's not universal coverage. And then our private insurance industry just announced that they're raising all of our premiums 10%, and they're saying that's because of the cost of the reform. So in Massachusetts, we've spent a lot of money. We've managed to cover about half of the uninsured through Medicaid expansion of Medicaid-like programs. We've given the insurance industry absolutely everything they wanted, and what we're getting is higher prices and still having uninsured people in the state.
That's Dr. Steffi Wohlhandler. And Physicians for National Health Program have come out against the Senate bill, said don't support it like Dr. Howard Dean has. But your comments on her assessment of your plan in Massachusetts.
Yeah, Dr. Wohlhandler and I disagree on this. And the numbers that have come out over the last couple of years have really shown a dramatic change. By the most recent numbers, and it's been confirmed again after a year, we're down to 2.5% uninsured. They're at a time when the recession dramatically ballooned the rolls of uninsured in every other state. Massachusetts went in the other direction. And then the idea that the costs have gone up, they have. They've risen about 8%. Just like every other state in the country. The reform plan in Massachusetts did nothing on cost. It didn't explode the budget to do something about the uninsured. It is providing care in ways that are making dramatic differences in people's lives, and I see it. I had a 19-year-old patient 2.5 years ago who had a metastatic cancer. I'm a cancer surgeon. We did the operation. She had college coverage. It capped out at $75,000, and then we were scrambling for chemotherapy and radiation, and she forewent it for almost a year because she didn't want her family to deal with the cost. I haven't seen a case like that in 2 years. It is dramatic, and I think we can't lose sight of that public health value. The reform bill underway, though, does begin to do much more about cost, including addressing these problems that I really saw as the core of what's going on in McAllen. How do we create a different way of paying physicians and hospitals so that we're now have the reasons to, we're paid not for quantity of care, but actually for getting better results.
We're going to go to break, then we're going to come back. Dr. Atul Gawande is our guest. His book is called The Checklist Manifesto, How to Get Things Right. I want to talk to you about your research on the other countries in the world and the systems they have, and then very interesting on solitary confinement, on the effect on human beings as social animals. This is Democracy Now!, democracynow.org, The War and Peace Report. We'll be back in a minute. A Walk with Thee, Eddie Gale, here on Democracy Now!, democracynow.org, The War and Peace Report. I'm Amy Goodman with Sharif Abdel-Quddus, our guest for the hour, Dr. Atul Gawande, and we'd like to get your comments as well. You can email us questions or comments at stories@democracynow.org. Dr. Gawande's latest book is called The Checklist Manifesto. He's a staff writer at the New Yorker magazine. He's a cancer surgeon at Brigham and Womens Hospital. He's at Harvard as well. Dr. Gawande, the other countries that you've looked at and the systems that they have, from France to Australia to Britain to Canada, how do they compare to the United States?
They have much more equitable coverage, and that's a base equitable coverage. That's a fundamental value that they've embraced long before we have, that everybody would be covered for care. Second of all, they have been able to organize care in ways that we're seeing, for example, service. In most of Europe, there are evening hours for primary care physicians, and that's not something we have here. Most of the systems have, in Europe, have computerized records, which has allowed them to work on improving safety and being able to make sense of care in ways that that work with cost. There are aspects of care that are not as good. We are very good in management, for example, of cancer care, and they're taking lessons from us. So I'm not going to say that things are perfect, but our unwillingness to learn from other examples will hurt us in the long run.
What do you make of the media's vilification of anything other than we have so that people can't make a rational assessment? You're making a political decision everywhere else. Do you want to be a socialist, or do you want to have good medical care is basically the question.
Yeah. And my only way to go at it is to say, let's just solve problems. In our surgical work, we said, show me ideas from the best systems in the world of what the way care should be. And what we identified were 19 steps that were the kind of best practices, and some came from, our hospital at the Brigham and Womens Hospital, Johns Hopkins, Toronto. I also got some ideas from Tanzania, from New Delhi.
Like what?
In our checklist, for example, we had learned that there were systems in other parts of the world where we make sure that everybody in the room is introduced by name. And that improved the likelihood that the team actually functioned as a team, and a nurse could speak up when they recognized a problem, that they felt they had the voice to be able to say, stop for a second. So when we created this, we said, we're just going to take the best ideas, implement them, and then we implemented them not just in the United States. We wanted to see, does it matter in Toronto? Does it matter in Jordan? Does it matter in Manila? And everywhere we put the system in, we reduced complications and deaths by double-digit figures.
How did other countries develop their systems?
It's always by a hodgepodge. We think that, Britain got its totally government-run system, or France its largely union-developed system, or Switzerland its entirely private insurance system, because a bunch of people sat in a committee room and said, what's the best system we could come up with? Instead, it has been through historical accident over and over again. World War II led Britain to, under the bombing attacks from Germany, to have to shift its entire population to the rural countryside. If they were going to survive, the government had to build hospitals, and suddenly they went from a private health system to a government system because of war requirements. And so it was Churchill, the conservative, who led the campaign saying, let's make sure we have coverage for people, and let's build on the system we have. Well, the system they had was government coverage.